Okay, thank you once again for being with us today. I just emailed the other case study for today. What we're going to do is just speak briefly right now. We're going to review the types of reports, the types of assessments, and narcotic management, because these are important for the golden hour of clinical experience. And there's a recording that is on, it's either on College of Health and Allied Development YouTube page or uh, Conversations with Kerry YouTube page, and it speaks about the golden hour. I think there are uh, two presentations. One, at the end of one presentation, the feedback that we got from the audience kind of indicated to me that there were some things that they just didn't get. And so there is another. So there should be two recordings regarding the golden hour, giving a further explanation. So I'm going to ask you to go ahead and find those two recordings on College of Health and Allied Development or Conversations with Carrie. And it speaks about the golden hour. What are some very important uh, steps and preparation to take to make your shift a success? Okay. All right. So reports. I actually have a video clip that I'll post. Well, it's actually an audio clip, but I'll post it online just to review um, the types of uh, reporting. Okay. Um, and actually, the video clip is not on all the types of reporting. It is specifically on the uh, shift change reporting. Okay. All right. So, so the types of reports include the change of shift report, which is the most important report. You have report to other members of the healthcare team regarding patient's progress or change of condition. And for that one, we use SBAR situation, what is happening with the patient. Now, um, another way I like to put it is what's the reason for this report? Patient's background, um, their reason for admission, the course of treatment so far, patient responses up to this time, and then any medical history of the patient. So that's the background. Then you have the assessment is what does my current assessment of the patient uh, tell me? What is the patient's blood pressure now, heart rate now? What is their signs and symptoms now? Okay, which also is aligned with the situation, the reason for the call, or the reason for giving the report. And then the R is for uh, recommendation. Okay, you also have uh, another aspect, which is ISBARR. And as you can see, S bar is in it, right? But there's an I at the front. And the I is for introduction. When you pick up that phone, you're going to say, for example, you're giving the report via telephone. You're going to say who you are, where you're calling from, the name of the patient that this call is in regards to, right? So that's an introduction to what it is you're about to say. Then you tell the reason for the call, which is the situation. Then you tell the patient's background. Then you tell the patient's current assessment. And then you make recommendations. You know what, most of the times we know what is going on and we know what it is that we need. But if we don't know, then we wait for the doctor's recommendation. And then, so that's the S bar. And the R that is added to the end is for what they call read back, or here's where we ask for clarifications. Here's where we tell what it is that we think we heard, and for the doctor or the receiver to clarify that, yes, indeed, that is the recommendation. All right. So you have ISBARR. Okay. And they still consider that that the S bar is still within that, except they've added the introduction part and the readback part. Okay. All right. So that is the first one we want to talk about. I did promise that this was going to take about 30 minutes. All right. So that's the first of the those are two of the reports that we're going to be looking at on today: the handoff report and giving reports to others. Now, the handoff report, okay, or what they call the change of shift report, this is very important because this is how you get to know the patients that you are taking over. All right. And this is very, very important for continuity of care. Okay, and some of the things we want to make sure is included when you're giving report are: number one, that you're not in a rush. Okay, the person who's giving report is not in a rush to just hand off and leave. All right, and the nurse that's receiving the report is present, is prepared, and understands and ask questions. Okay, because sometimes the nurse may be giving report and may forget a particular detail. But if you know what it is that you're expecting, okay, not in terms of the patient's condition, but in terms of topic or role, then it's easy for you to recognize when something may be missing and to ask that question. So now I'm going to go through just some of the items that should be included in a change of shift report. Now, this change of shift report should be taking place in the patient's room in front of the patient. Okay, this is how you're able to see and do some initial assessment of the patient. Okay, too many times persons give report and it's not in front of the patient, and when you see the patient, it's like a totally different scenario. Very many times patients have even passed away, and the report that is being given, it's regarding, say, a patient that is alive. When you enter the room, the patient is not alive. Okay, so the handoff report needs to be done in front of the patient, where the nurse giving the report, the nurse receiving the report is seeing the same things. And it also helps to clarify certain information. Do you remember which arm the IV is in? Is it in the right hand or the left brachial area? Some of these questions are answered during the handoff report, where you do your rounds and the reporting is done in front of the patient. Okay, so the change of shift report should include the patient's name, the patient's age, the patient's code status, the patient's diagnosis, which includes admitting diagnosis and medical history. All right, their allergies, if any, We also want to include uh, uh, chief complaints, because the diagnosis is one thing, but as you've learned, a particular diagnosis may come with various uh, different types of signs and symptoms. So what we want to know are, what are the patient's chief complaints as it relates to their diagnosis. Okay, if the patient has any lines, tubes, and drains, such as IV lines, uh, uh, any tubes like endotracheal tubes, any drains such as Foley catheter or JP drains or hemovac drains. Okay, we want to know what the patient's activities are. Are they ambulant? Are they on bed rest? If they, can they mobilize? How do they mobilize? Do they use support equipment? All right. We want to know uh, the patient's preferences. Okay, especially in the long-term care, how does the patient take their medication? What time the patient wants to get out? What's the patient's preference when it comes to activities, engagements, right? Ambulation, rehab. Do they prefer to go to rehab in the mornings, in the afternoon, or in the evenings? Okay, so these preferences have to be ascertained. All right, what diet are they on? Uh, Not just the diet, but also the consistency. Are they on a regular diet of puree consistency? Are they on a renal diet? Right. Uh, we want to know if they have tests or procedures. Were any done? Were any scheduled? Do we have the results yet? Are the results pending? All right. We want to know their psychosocial history. For example, yesterday, uh, there was this patient, and the patient had real high emotional expressions. And then the nurse said, "Oh, he's been here for like 4 years," and expressed some of the social events regarding, or the psychosocial events regarding his family, their engagement, etc. Okay, there's another patient who uh, responds, or who is triggered by certain things. So these are important to know, and these are psychosocial because it depends with the patient's cognitive function and how they engage with their families, the nurses, and even the environment. All right, so that would be psychosocial. We want to know in the report, the change of shift reporting, if the patients have any medications that are added, any medications that are discontinued, any medication reactions, or even patients' responses to medications and treatments. All right, we want to know if they have any pending appointments, or if they have any new consultations, if there has been any change of condition during the shift. Change of conditions can happen at any time. So if there were any change of conditions during the shift, then it's important for that to be communicated as well. All right. Uh, so these are some of the things that we need to know. Also, any additional focused assessments. Okay. And we're going to speak about assessments in a little bit. So the focused assessment is, for example, patient came in with this particular diagnosis. So typically, we fo- we focus on those areas. But then, if there was any, as we say, change, the patient came in because the patient maybe uh, had a fall with a fracture, and they're getting their orthopedic care. But what if the patient complained during the shift that they are having abdominal pain? Okay, that would be a change in condition, and then you'd give a focused assessment about that area. All right. So these are some of the things that needs to be in a change of shift report. If the change of shift report is not what we call rounding, where you go in, see the patient, you give the report, then it is not proper change of shift report. If you do not have these basic information, then it is not a true change of shift report, okay? So these are the things we want to ensure that we are getting in change of shift report. Any questions about change of shift reporting? Any questions? Okay, I'm also going to submit uh, documentation that will give some information, some more information about reporting and the change of shift report, and especially why it is so important. Okay, so that you can have that also for follow-up. Okay, so we spoke a little bit about reports. We looked at two, change of shift report and giving a report to members of the team. We looked at SBAR and we did a deep dive into the change of shift reporting because that's step number one in caring for our patients, okay, or reports. Then let's talk a little bit about nursing assessments. There are four major nursing assessments. All right. Assessment is the first step in the nursing process. Before you can do anything for a patient, you need assessment. You need, and of course, we're not going to get into like the different types of information that are in assessments, but I will share with you the four major types of assessment. The first is the comprehensive, and this assessment is where you look at the holistic picture of the patient. All right, their chief complete, well, objective and subjective data, their psychosocial, their spiritual, everything related to the patient. Here's where we get to know them. So we cover all the aspects of the patient, okay? We do tests and procedures to see what the body is telling us about the patient, okay? So subjective and objective data, all right? Then you have what is called focused assessment or problem-oriented assessment. One of the examples I gave you is if a patient is complaining of abdominal pain, your assessment would now be focused on the gastrointestinal system, okay? And we focus there. Then we have the emergency assessment. This is rapid assessments to help us to quickly identify what may be going wrong with a patient. Okay, so if we see the patients with signs and symptoms of a stroke or cardiac arrest, these are some examples of emergencies. All right, then you would do emergency assessment. For cardiac arrest, you would be doing the CABD. All right, and for a stroke, we would be using the stroke mnemonic to quickly identify if is this a cardiac arrest, is this a stroke? All right, so you have emergency assessment, and then you have the time lapse assessment. So the time lapse assessment usually comes off the comprehensive assessment. So you completed the comprehensive assessment, but now the patient is here for a few days. So you don't do a comprehensive assessment each time, right? You do a brief assessment that is focused on the changes taking place in the patient. Okay, so the patient came in, as we said, fall fall with fracture. All right, so we assess how the time lapse assessment would be focused on how is the patient physical condition as it relates to healing. How has that changed their psychosocial presentation? For example, when they first came, they were probably in a lot of pain. So you assess for pain. Pain is improving because of medication. They may have been withdrawn and sad, maybe worried because uh, they're not able to be at work, what's happening with their families, what's happening with their jobs, etc. Now, how is the patient coping with the situation at hand? So this is what the time lapse tells us, how the patient came in and how after intervention and time, what is their current state of being now. Okay, so that's a time lapse assessment. And so many times when we take report, right, we are taking report based on time lapse. Okay, but if we're doing a new admission, it's a comprehensive assessment. Okay, uh, so so let me ask this question. You're in, you're on the street. I'm taking it to the street now. I'm taking it to the street and somebody falls in right in front of you. What kind of assessment would be necessary there? Anyone? Oh, I'm not hearing you. Go ahead. Remember to unmute to speak.
Sorry, miss. Could you repeat that? I was paying attention to my sister going out. I'm sorry.
If you are on the street, right, your sister is going out now. What if, as she's going through the door, you see her fall to the ground? What kind of assessment would that be? What kind of assessment would you engage at that time? Would it be comprehensive assessment, problem-oriented assessment, or focused assessment, emergency assessment, or time-lapse assessment?
That would be an emergency, miss.
Okay, that would be an emergency assessment. You want to find out very quickly what the situation is. Okay. At what point would you engage the comprehensive assessment? At what point would you engage the comprehensive assessment? You would engage the comprehensive assessment if she's being admitted. Okay? Do you get that?
Yes, miss.
Okay. All right. And at what point would time lapse assessment begin?
After she's admitted and there for a while, miss.
Okay, so that your time lapse assessment would be now your shift assessment. So when she's admitted to the hospital, that's well, um, the emergency assessment was conducted when the situation first occurred. The comprehensive assessment when the person is admitted. The time lapse assessment now is done at the beginning of each shift, during the shift, and at the end of the shift as the situation arises. But typically, the beginning of the shift, you do an assessment. So that would be time lapse assessment at the beginning of the shift. Okay. And then if there are any complaints during the shift, then focused assessment or problem oriented assessment would then ensue. All right. So there you have a little synopsis of the different types of assessments and when they are used, when they're appropriate to be used. So in an emergency, you're not going to try to do a comprehensive assessment. In an emergency, you're going straight to the issue, all right, to get the enough information to be able to save this patient's life. All right. Uh, Any any questions there? Any questions? Okay. Hearing none, I move on. So the other thing I want to speak to us briefly about is narcotic management. And this is very important, narcotic management, because narcotics are mandated. Well, narcotics are used in healthcare, and they are the authority over narcotic management is the Drug Enforcement Agency, which is a federal agency. And so narcotics have to be handled in a way that shows what we call chain of custody. All right. And I decided that we would speak about this because different facilities uh, conduct their chain of custodies differently, but the chain of custody is very critical. Okay. Uh, for narcotic management, uh, it's documented uh, each time there is engagement with uh, the narcotics. Okay, so for example, this is a brand new unit. This unit is going to be open for the very first time. Okay, and the administration decides that we're going to take patients here that will have pain. And so we're going to keep certain types of narcotics for pain management on the unit. So there has to be documentation of the name of the narcotics, the preparation of the narcotics, whether it's injectable, whether it's tablets, whether it's solution, right? Whether it's inhalation, that's what's called preparation. Okay, the preparation of the narcotic. Then the amount, how much. So if you let's just take one for example, you're going to have Percocet. Okay, uh, Percocet 10 milligrams tablets, and you're going to have 15 10-milligram tablets. So that needs to be clear. It's Percocet, it's tablets, the amount is 15. And the person responsible for the narcotic is going to count the narcotics, verify the name, the preparation, the dosage, and the amount. And they're going to document that. And both persons are going to sign in agreement that I gave this person Percocet 10 milligrams tablets and the amount of 15. So I'm signing that I gave that amount, and the person receiving is signing to say that they received that amount. So you have two signatures there. And so if nobody used the medication, nobody used Percocet, at the end of each shift, you still have to check and document and sign. Check, document, and sign. So over 5 days, if you have 12-hour shifts, every day at the beginning of the shift and at the end of the shift, you see a drug count and two signatures. Okay. Now, what if on, say, the 8th day, somebody was having pain and the nurse with the keys? Okay, that's another thing we need to talk about. Narcotics are managed under what they call double locks. Okay, So it must be in a locked container, in a locked room. If the room is not going to be kept locked, then the place where the narcotic is kept must have two locks. So they may have a locked cabinet, and in the locked cabinet, you have uh, the locked, whatever it is, kit that the drug is in. Okay, so there must be double locks going to the narcotic. That's number one. So typically, there's one person responsible for that last access key to get to the narcotic. So that person must be present. That person, um, say, for example, uh, I have the key and a nurse wants narcotics for their patient. So we both go into the room. We open the cabinet, then we open the kit. We first count to make sure that how the amount of narcotic that you say we have is the amount of narcotic that is present. That's the first thing you do. Then you remove the amount you need. So if you needed one tablet, you would remove that one tablet. And then you're documenting uh, Percocet, 10 milligrams, tablet, 15 minus 1, remainder 14, and you're signing. Okay? Now at the end of the shift, when it's handover time, when you're handing over the key, the oncoming person that's going to take responsibility for the narcotic will then count with the person giving the narcotics over to say, okay, you started on the shift with 15, one patient got one tablet, and now there are 14 remaining. So I'm signing to say I gave you 14 tablets of Percocet 10 milligrams tablet. And the receiving nurse is signing to say I'm receiving 14 tablets of Percocet 10 milligram. Okay. And so this is what the chain of custody is about. It's about documenting the narcotic as the shifts change and as the patients get medication from it. Now, we don't just do it for doing sake. The pharmacist monitors to ensure, well, first of all, is the person responsible monitors, the nursing supervisor monitors, the nursing director monitors, the pharmacy monitors as well. And if there are any changes or any discrepancies, they are investigated immediately. Different facilities determine um, how they investigate their processes for um, resolving that discrepancy. If the discrepancy is not resolved, it has to be reported to the Drug Enforcement Agency. Yes. Plus, in addition to that, every month, the report is submitted to the Drug Enforcement Agency to show all the people in contact with narcotics, and the shows a chain of custody and the dispensing of the medication to show that none is being used for reasons outside of uh, treatment for patients' pain. Okay. So, as we said, different facilities have different ways of managing They're narcotics. Some persons do the management on paper, some do it electronically. But the principles of the chain of custody, where one person receives it, signs, the person handing over signs, the person receiving signs, and at each juncture, there has to be documentation. Every change of shift or every time the drug is used. Now, there is something called waste. Okay. Say, for example, you have that same Percocet, 10 milligrams, but the doctor only ordered 5 milligrams. They are scored so they can be broken in two. Okay. What do you do with that half? Now, there are some facilities, some pharmacies that will give you exactly the dose that is necessary based on the patient's order. And there are some where you may have to break. Now, if you break it, you don't put the medication back, you discard it. So that would be documented as waste. That waste has to be witnessed. Someone has to be there to prove, to verify, to testify that, yes, I saw her break it in two. The patient got half, and the other half was flushed in the toilet or crushed and discarded off down the sink, or however it is that the facility determines that these drugs are to be wasted. Okay. Sometimes it is kept for verification by the director of nurses and then discarded with a pharmacist. Okay. So every facility determines how they meet that criteria. The thing we want you to know is that waste also has to be documented and it has to be witnessed, okay, and verified via documentation, okay? So it's not just arbitrary, all right? So any questions regarding narcotic management?
Miss, what if the patient getting a narcotic cannot sign? How would that go?
The patient is not the one that signs. It's the nurse. It's the nurses who sign. The patient does not sign. The patient just receives the medication. The nurse that is uh, take that is taking the medication out for the patient, they're the ones that signs. The nurse handing over to the next shift signs. The nurse receiving from the shift signs, not the patient.
Okay.
All right. Thank you for that question. Any other questions regarding narcotic management? Now, there are so many things I could tell you about narcotic management, but I'm not going to get in it today. Um, this is just a brief review, and we deal with it at length in the in a pharmacology class and also legal aspects class because mismanagement can come with federal charges. Okay, if the narcotics are being diverted for personal use or for sale on the black market or whatever it is, it comes with federal charges, including imprisonment. Okay, so narcotic management is very, very important. All right, we need to the uh, follow the procedures set out by the facility. So you understand the concepts, you understand the principles, you understand why it's important. So, determines that they, um, however, the facility determines that they manage or meets this chain of custody for narcotic management, that is what we do. Now, what if a person works at multiple locations? You have to do what the location that you're working at right now dictates. When you go to the other facility, however the facility does it, then that you do. All right. Those are the rules. Any questions? No. Okay. So I sent to you the case study. So I want you to do the case study and we will meet today at 3 p.m. and we're going to go through the case studies and to answer any additional questions that may have come up um, as you go through the day or the scenario, all right, including any questions from the topics we covered today, reports, assessments, and narcotic management, okay?
What was that website you said to go on?
We have, uh, it's on YouTube, College of Health and Allied Development, or Conversations with Kerry.
I put in conversation with Kerry, but it is telling me about the Kerry in the public the America system.
Okay, so put Conversations with Kerry Nurse and let me know what comes up. Expert calls for amendments to flexi work legislation to allow federally enabled funds to measure care for aging relatives. Slide 7 is your 30-minute news package, which today is brought to you. This was brought to you by Rotating Fast Secure.
My computer not turn on.
In General Insurance Jamaica Limited, it's safe and easy. A financial report by Jane Bank Small Business Loans. And help you find a way. And we just heard the Breakfast Sports Report. Lasco flavored is so and make nutrition. So good.
So, let me do it.
Oh, there it is. I'll give it to you. I'm dropping the link in the chat. Oh yeah, golden eye. Okay.
Is it the one with private help, miss?
I put the link in the chat.
Oh, okay, miss. All right, thanks.
I'm putting both the links in the chat. Okay, so there you have it. Alrighty. All right, so you have a good day. So I will send you the link for 3 p.m. Okay, I look forward to seeing you then.
Okay, miss, thank you.
You're welcome.